Doctor, how you are doing with rituximab during the COVID-19 pandemic, and how you are managing the patient with vasculitis related to this?
Great question. Thank you, Doctor. So definitely in the early phases of the pandemic, we have been limiting almost all IV medications and trying to give the patients like sub-Q substitutions if we're talking about rheumatoid arthritis or other diseases. However, there is a certain population that still need rituximab, especially like patients with vasculitis. We have been advising patients to take the vaccine, and we've been timing the vaccination with the rituximab doses according to the most recent recommendations and going ahead with the treatment.
Do you think that COVID-19 will make a hard time for us for systemic connective tissue disease for the next 5 to 10 years? The picture of vasculitis will be changed, or it will be no change?
It's hard to tell. I've been seeing cases of vasculitis triggered by COVID infection. So as we know, vasculitis or any of our rheumatic diseases can be triggered by a virus. And I've seen a relapsing case of GPA in my practice who was doing really well on azathioprine, relapsed because of a COVID infection. And that patient, we use rituximab to treat his flare, and he's done very well.
And do you think that avacopan will be an steroid-sparing agent?
It's hard to tell. Like the studies are promising, but not really sure about the cost and availability yet.
Dr. Ibrahim, we are always accusing the patient to refer for uveitis or oral genital ulcer as he's a Behçet disease. In your clinical experience, what is the tricky, the home message, how we can proper diagnose Behçet disease by lab and by clinical examination? Not each patient with genital ulcer or ulcer, it is Behçet disease.
So that's a...
Yeah.
Thank you. The question is how to capture patient with Behçet disease who may present with simple presentation before they present with major organ. The challenge is divided. So to answer you, sometimes we tend to have patients referred from other specialty where they see classical presentation of a disease, but from your point of view, due to the lack of other systemic organ involvement, you think, I'm not sure that this is Behçet wala la. Although we call them incomplete because they are not meeting classification criteria. When you look at their outcome, treatment option, we usually treat them more or less the same. The majority of those patients who عادةً are the uveitis patient. And we do have data on treating those patients aggressively with anti-TNF, irrespective of the classification criteria. And really the reason is that the bad consequences of not treating, which is loss of the eye and damage. وهي based على a subgroup of patients that were falling within Vision 1 and Vision 2 trial. We were using Humira particularly for the treatment of Behçet. Now when it comes to recurrent oral genital ulcers, these are simple. How we can capture them? First of all, I think there is awareness component. So we need to focus with our colleagues in family and dentistry, which is a very important part, about the early referral patient of Behçet. Second part, unfortunately, until now with Behçet disease, we don't have a very good lab to correlate or predict the disease. We know that inflammatory markers do not correlate very well with Behçet disease activity. So you may have someone who is really good, but they have elevated inflammatory markers. But you can't use that per se. So in the absence of other organ involvement, I would say that it might be difficult. And in addition, in the absence of other organ involvement, those patients will be recurrent oral ulcer, and the most common cause is really iatrogenic or unknown, rather than truly Behçet. But they might share some immunological changes, and that's why sometimes we use, in my practice, I use some of the data, for example, apremilast or colchicine, extrapolated and used in those with refractory oral ulcers who do not fit the classification criteria, and they do well, some of them. So we still can do that. but after doing our due diligence and doing the biopsy and whatnot. آخر شيء I want to highlight with this part is the fact that in patients who tend to have familial history and they have features of Bahjat, very important to send them for genetic testing for NF-kappa B mutations or the haplotype insufficiency recently reported. You know, هذول patient tend to have might have an increased risk of infection, and two, they would require a treatment with anti-TNF whatnot. فيعني I think it's worth to think about.
Yes, for both of you, to depend on the clear diagnosis of vasculitis or with Behçet, it will take 1 to 2 weeks. How you can tackle the patient with acute presentation with high ESR, high positive CRP high, complement is normal, bending autoantibodies and the patient in a critical situation. You will manage in rush or you will wait for something solid data for medical legal purpose?
It's a good question. You're talking about a wide spectrum of disease, so really depending on which disease I'm dealing with. Starting my practice, I was more conservative. More recently, I've been so aggressive. So again, with covering the medical legal issues, we have to have a solid, objective evidence to base our decision to treat aggressively on. So I would not just go with laboratory ESR or CRP, but if I have, for example, a picture of GCA with a high, inflammatory markers, there is headaches, and even if I'm waiting for the biopsy, we still have to be aggressive. Similar for ANCA vasculitis and Behçet disease, if I have a uveitis or an organ-threatening disease, even if I don't have the complete picture of the diagnosis, I would go aggressive.
It's okay.
Second thing, نعرف إن المفروض we never contradict a female فيعني with the new vision. لكنه so I agree with رؤى. I think our specialty is the best specialty deals with uncertainty. Majority of what we deal with is uncertainty. So in general, I usually approach this from two parts. One, what am I losing by not treating? So major organ, is there a life-threatening situation? And if that's the case, what is my concern if I use the treatment? Usually it's an infection risk. And in those situations, I usually make sure that the patient is covered. Once they are covered, you have really plenty of opportunity to use things temporarily. Usually the use of steroid in life-threatening situation is totally reasonable. And remember that in severe sepsis, we use a steroid. So it's not the end of the world. Having said that, obviously, steroid kills, infection is bad. So if you have a documented infection or the suspicion is high, obviously, hold tight. But I think there is dealing with uncertainty in life-threatening situations straightforward. You have what am I gonna lose if I'm not treating the patient, and can I cover him with something else temporarily?
Thank you. Dr. Emilio is there? He's not there. Okay. Any further comment or questions? It's okay. Thank you to all of you, and have a safe trip. And still, we have a session after praying, inshallah.